it will be about dermatology cases. So I will share the first case on the screen. So any doctor want to take the case, he is most welcome. So this,
I can take it.
okay, Dr. Amr, for sure. This is our case. So now, Dr. Amr, you have 5 minutes. Prepare yourself. This is a station 5 case.
Okay, thank you.
If you are ready at any time, just tell me, please.
Okay, just 1 minute, please.
Take your time. It's okay. Still, you have 3 minutes.
이미 말지 नहीं होगा यानी कल के नहीं तुम्हें
Yes, Dr. Khalid, I'm ready.
Yes, Dr. Amr. You can hear me now?
Yes, I can hear you.
Okay, Dr. Amr, 1 minute. I'll make a timer for you so that you can start. Okay, Dr. Amr, go on.
Okay, good evening, Mrs. Brown. I am Dr. Amr. I am one of the medical doctor.
Welcome.
How are you?
I'm good, thank you.
Can I confirm your age? You are 37 years old.
Yes, doctor, I'm 37.
Okay, I understand that you have been referred to me because of skin rash.
Yeah.
Can you tell me more about that?
Well, doctor, so for the last 4 weeks, I started to have rash on my body. It's more in the in both lower limbs. It's on my leg. You know, doctor, I'm very afraid. I don't know what's going wrong with me. This rash appeared suddenly for the last 4 weeks.
Okay, I'm sorry to hear about that.
Thank you.
So it started suddenly for 4 weeks and it has been increasing?
Yes, it's increasing, yes, more and more.
Okay, is it painful?
No, doctor, no pain at all.
Is it itchy? Like you have
Itchy.
to scratch it?
Itchy. I cannot remember something like this. No.
Okay. Can you show me the rash?
Sure, doctor. I will show you now. The rash.
Until you show me, can you tell me what's increasing? Anything specific can make it worse?
Never, doctor. Nothing makes it worse.
Okay. Anything like sun exposure, for example?
Sun exposure, no. Nothing make it worse at all. This is the rash, doctor. You can see it, huh?
Yeah, I can see. And this is only in your leg.
It's on my leg, and it's spreading to my both hands and my back as well.
Your hands and your back.
Yes.
Okay. Did you ever have anything like this before?
No, doctor. This is the first time for me.
Okay. How did this rash start?
It starts suddenly. I don't know what happened, but it starts on my left leg, then started to increase, then my right leg, then my back, then my hands, increasing.
I mean, did it start like a sack or just spots?
No, spots.
Spots. Is this one? Can you? Is it balanceable with your hand, or can you palpable or not?
Palpable? No, doctor. I cannot feel anything, but I don't know what's been by planchable.
I mean palpable. Yani you can feel it with your hand.
No, never.
Okay.
You know, doctor, it's like an ink. You know, ink, red ink.
Yeah, I can see. Okay. So I understand that you are could be pregnant also.
Pregnant? No, the last time I have my period maybe 2 weeks ago.
2 weeks ago.
Yes.
Okay, so you are in a long-term relationship.
I'm married, doctor.
You are married. Do you have any children?
Yes, I have my children. One is 3-year-old.
Any previous miscarriages?
No, never.
Okay. Any previous clots in your legs or your brain?
Never. I didn't have anything like this before.
Okay. Do you have any abdominal pain?
Abdominal pain, tummy pain, you mean? No, doctor, but I'm having some, you know, I'm having some water brush, you know, some water brush. I feel acid in my gullet sometimes. I don't know, is it related or no?
Okay. Okay. Do you have any joint pain?
Joint pain? No, I don't.
Any bleeding from your back passages?
Bleeding? No, I don't have.
Any bleeding from anywhere else, like coughing up blood or throwing up blood?
Yeah, I don't know, but I feel yes. Sometimes I have some blood from my nose, but it's not that severe. I can clean it with my tissue. It's mild.
Okay, you have this since a long time or just recently?
For the last 3 weeks as well.
Okay. Are you in any regular medication, Mrs. Brown?
No, I occasionally use this paracetamol only.
Okay. Anything else?
No, doctor.
Okay. Sorry to ask you about this. Any listed drug, any recreational drug you are using?
No, doctor. I'm a conservative person, by the way.
Sure, I understand.
Thank you.
Any oral ulcer or any ulcer in your private area?
No, never.
Okay. Can we see the rash in her back? And
It's the same, doctor. The same rash.
all the same. Okay. What do you do for a living?
I'm working as a secretary.
Okay. And what is the impact of this in your life?
You know, doctor, it's affecting me badly. I feel depressed because I cannot wear my regular clothes in my work, and even if I'm going with my friends, I cannot wear well. Now I'm wearing long shirts, long pants. It's affecting me. I'm depressed. I feel I'm depressed.
Okay, I'm sorry to hear about this. We'll take care of you. We'll get to the bottom of this. And well, any travel history recently?
No, doctor.
Okay. Any? Do you smoke?
No. 1 minute remaining.
What is your concern?
Doctor, I'm afraid I'm sure maybe I'm having a cancer or something like this, because I read that cancer sometimes come with this rash. I'm afraid of this. What's going wrong with me? I need treatment for this as well.
No, I want to assure you, I don't think this is cancer. I think it is something else, something relating to your defense system. Like when we call it autoimmune, you don't bother by the name. This is when your own defense system is attacking your body, and something like this will result. Okay, but I don't think this is cancer. Can I ask, do you have any weather preference?
No, doctor.
Okay, any loose motion or loose weight?
No, doctor.
Okay. Any increase of your pigmentation in your body?
Time.
Okay.
Thank you. 2 minutes for questions. Okay, doctor. What's your differential diagnosis?
So this looks like a berberic rash. It's not palpable. It could be immune thrombocytopenic berbera. Also, I was suspecting Henoch line berbera, but there is no associated arthritis or abdominal pain. I suspected also drug or medication induced, but she's not on any regular medication. She's not taking any drug that can cause that issue.
Okay, so how would you investigate this patient?
So we'll start by doing CBC. We'll also do like coagulation profile, fibrinogen. We'll do basic screen to check her renal profile for any involvement. Also, for any involvement of hemolytic urine syndrome. She's not toxic, so it doesn't look like that. But we have to check her renal profile. Also check other autoimmune like thyroid profile and adrenals. We'll perform a multidisciplinary team, including hematology and rheumatology. I will discuss the case with my seniors and my consultant to construct a differential diagnosis and a management plan.
Okay, thank you, doctor. Thank you. Thank you,
Thank
Dr.
you.
Amr. You did a good job, mashallah. I'm not sure if you find it easy or, it's not that easy case and it's not that smooth case. For this
I'm not
case,
sure about the diagnosis actually.
Okay, don't worry about the diagnosis. We will come to the diagnosis, inshallah, because we have an algorithm for this. It will be very easy, inshallah, and you will catch the diagnosis within the first 1 minute or 1:30 or the second minute, inshallah, by the way. But let's comment on some things. The first skill is a clinical communication skill. Yes, you took a good part, you took the history in a good way as regard this berbera. But doctor, when the patient tells you that there is another symptom, you have to analyze the other symptom very quickly. The examiner or the exam, they will not give you a symptom without need. For example, this patient she told you that she is having reflux. She told you that she is having water brush. So you have to analyze it very rapidly. The other thing,
I forget to ask about it.
Yes. The other thing, by the end of the discussion, the patient told you that she feels depressed. Okay. Do you think that this will be safe to discharge a patient telling you that she is having some depression, please note this. Okay.
Okay.
So this is an important point. At least you have to ask her two questions. What about your mood? She will tell you I am depressed. The second, tell her, okay, I'm so sorry for this. Do you have any bad ideas about life and death? She will tell you, no, doctor. Then tell her, tell her or ask her, did you try to hurt yourself in the last 1 month, for example, because she tells you she is depressed. So rapidly you can get if she is having a depression that needs urgent referral to the psychiatrist, or just this is mild depression. The second thing, the physical examination. Okay, you did well in the physical examination, but patient with skin rash, you have to check rapidly, or at least tell me that you want to check her back, for example. Her joints.
Chest.
Sorry.
Yes. Her chest and joints.
Very rapidly, joints very rapidly. At least these are the basics. Okay. For the clinical judgment, you told me that this patient is having ITP, but you didn't talk about the investigation, the main investigation of the ITP, which is the antibodies against platelets. Okay, not blood film, the antibodies against the platelets.
Yeah, sure.
Okay.
Sure.
Then identifying the physical signs, you will identify the physical sign. You conducted the differential diagnosis, but not all the causes of differential diagnosis, because we have lots of cases of differential diagnosis of non-palpable purpura. And finally, you maintain the patient welfare. I cannot judge such a thing. So to go to the point directly, we will have, inshallah, another case for Rash. We will discuss it today, but let's start first with how to approach to the case, a case of Rash. You know, the dermatology is a silly branch in the paces, but we have to deal with. So I will share on the share on the screen now. Bismillah. Okay, so doctors, you can see now. Doctors, you can see now.
Yes, Dr. Khalid, we can see.
Okay. Bismillah.
Yes.
So, okay, thank you. So now we will be talking about how to approach the case of Rash. Bismillah. Anyone knows how to make full screen? Sorry. Okay, from here, full screen. Do you see it as full screen?
No, it's not full screen, but it's still we can see good.
Not full screen. We have to zoom it to make full screen.
Okay. One second, doctors. I will make it. Bismillah. I don't know actually how to make it full screen, because they just changed
at
it.
the bottom left. There is a screen like a monitor.
Thank you. Okay, so doctors, how to reach the diagnosis in case of Rash? There is a common mnemonic for this in the analysis of Rash, which is biopsy, as we know. B for planchable. Please write down this, doctor, because you will not find it in this PDF. So biopsy. P for planchable, I for itching, O for oozing, B for bin, S for skin around it, and the skin in the floor of the skin around it and the skin over it. And why, if it is yellow, like in cases of this pseudoxanthoma elasticum. So if you find the patient with rash, you should ask him, how did it start? After making analysis of onset, course, duration, what increased, what decreased, effective treatment, date of last attack, then don't forget to ask him, how did it start? Because we will see the impact of it when it starts. It will change your approach. But the first question after analyzing the complaint itself, you should ask him here, is it itchy or not itchy? This is the first. because we have different differential diagnosis. If it is HE, so you will ask her another question. Do you feel any scales over it? Any small scales over it? So she will tell you yes or no. If it is scaly, you know, PEEL means someone scratching or making peels. So this will be the mnemonic for things, but it's not PEEL, it's BEL only. If it is not scaly, it may be one of the two things, either dermatitis herpetiformis or bullous pemphigoid. This is the first part of the mind map. The second part, if it is not HE rash from the start, so ask here, is it, or examine here, is this rash in a specific area, and we will see what do I mean with the specific areas. And if it is not in a specific area, so it may be berbera. So the first question from this case, the first question, do you have rash? Show me. Rash, show me. Remember, rash, show me immediately. Then HE or no? If it is not HE, so is it in a specific area like face, like trunk, like legs? No, it's not a specific area. It seems to be generalized. So it may be berbera. By the way, berbera, it is not a must for berbera to be generalized. So if it is berbera, it may be one of the two things. Non-palpable berbera or palpable berbera. If it is non-palpable berbera, and as this case, we have a mnemonic which is platelets V. Platelets V. Why platelets V? Because non-palpable berbera means that there is problem in the platelets, so that the blood comes out of the blood vessel, and it's like the ink on the paper. Okay, remember it well. Ink on the paper. But palpable berbera, the causes are itis. You know, itis means inflammation. It's a suffix, means inflammation. So palpable berbera is an inflammation, and the non-palpable berbera, this is platelet disorder. So from the start, do you have any rash? Okay, please, I'm sorry for this. Can you show me? She will show you the rash. Is it HE? No, it's not HE. Okay, it's not in a specific area, so it's a berbera. Do you feel it palpable? It's not palpable. See, this is the mnemonic for non-palpable berbera, and we can reach the diagnosis, inshallah, very early within the second minute. So we will take it from this point, whether it is when it is scaly or no. If it is scaly, so we said the mnemonic, it will be PEL. PEL. The first B. Think about it, doctor. I will not give you the answer, but at least you think about it.
Psoriasis.
Yes,
Psoriasis.
this is the psoriasis. The second one is eczema. Okay, and the third one is
Lichen planus.
lichen planus, for sure. So one on the flexor and the extensor surface, and two on the flexor surfaces. The two on the flexor surface are eczema and lichen planus, and the one on the extensor surface is the psoriasis. So psoriasis, it will be well demarcated, and these two are on the flexor surface, but one is ill demarcated and the other is well demarcated. Okay. If it is not scaly, so we are talking about blisters like dermatitis herpetiformis. It will be on extensor surface, and bullous pemphigoid on flexor surface. So this is an easy approach to reach the case of skin rash rapidly. We will not go deep in talking about psoriasis and dermatitis herpetiformis, and because we may discuss them in other sessions in the rheumatology and the GI. We may discuss them, inshallah. But for now, you have to know the broad lines of this. The second part of the algorithm, we will go back a little bit. Sorry, we said. We finished scaly. We will go to the we finished the HE, whether it is scaly or no, peel, dermatitis herpetiformis, bullous pemphigoid. If it is not scaly, so the rash will be in a specific area or no. We will see what do we mean by specific areas. The specific area may be face, So if you find the heliotrope rash, think about dermatomyositis. If it is butterfly rash, think about systemic lupus. If it is lupus erythematosus, think about sarcoidosis. By the way, rash can come also as a histostation. So you should mind on how to deliver your terms to the patient. So just tell him, does this rash includes your cheek or your cheek and the tip of your nose? If it is including the cheeks only and sparing the nose, so this is systemic lupus. If it is including also the nose, so this is lupus erythematosus, and think about sarcoidosis. If it is on the trunk, think about Chagrin patch in tuberous sclerosis, and then search for the intelligent cushions of those of those patients in tuberous sclerosis and other neurological affection. If you are talking about rash on the lower limb, see, we have pyoderma gangrenosum, erythema nodosum, necrobiosis diabeticorum, livido-reticularis, and ichthyosis. Okay, by the way, ichthyosis, yes, it can come more in the lower limb, but it can be generalized. The same with livido-reticularis. So please, doctor, remember these things. It's erythema nodosum, it's a painful nodule. Pyoderma gangrenosum, it's a painful ulcer. I put them in the red color both because both are painful. Next is necrobiosis diabeticorum, and it's easy to catch it. And the livido-reticularis, you know, livido-reticularis, if it comes in a station 2 history, the patient will tell you that I'm having a Fisherman's network rash. If it is ichthyosis, he will tell you I'm having fish scale skin. So let's have a look. What do you think about this rash, doctors?
Erythema nodosum.
Yes, this is erythema nodosum.
Nodosum.
Yes, it's a painful rash on both lower limbs. It can be symmetrical, and it can come at only one limb. And see, the case can come like this. Patient came with painful rash on his lower limb. So a patient came with painful rash at his lower limb. You will go back again. If you allow me to go back again, please, we will come from here. Is it itchy or no? No, it is not itchy. So search for a specific area. You are looking to the rash now. For example, patient came with erythema nodosum in both lower limbs, and he is having some shortness of breath and some fever. What will you think?
Sarcoidosis at the top.
It may be sarcoidosis, but he is having fever. It may be pneumonia, for example. TB.
Ammonia,
Yes.
tuberculosis,
TB, yes.
sarcoidosis, yes.
Yes. So what are the causes of erythema nodosum? We will try, inshallah, we will try to get the causes in all our stations. We will try to get the causes from the name of the disease itself, because I know that lots of mnemonics may make us confused. So erythema nodosum, it's a painful nodule. So the causes are nodosum. The causes are nodosum. No cause, drugs like sulfa and penicillin. This is for D. O for oral contraceptive pills. S for sarcoidosis and TB. U for ulcerative colitis, Crohn's and basic disease. And M for microaneurysms, special Streptococcus pneumoniae. And this is the most common cause of erythema nodosum, which is pneumococci. This is the most common cause. C, so nodosum is the most common cause, nodosum is the mnemonic for the causes of erythema nodosum. Sorry. The station, rash cases or dermatology cases may be very easy, and you can capture them very early without need for this algorithm. But the problem is if you saw a rash and you don't know, you should go with the algorithm directly. So if you saw a rash and you think that this is an erythema nodosum, is it painful or no? It will tell you no, it is painful and non-itchy. So think about erythema nodosum. Okay, so doctors, what do you think about this rash?
Livido-reticularis.
Yes, livido-reticularis. Okay, livido-reticularis. So what are the causes of livido-reticularis? You know, the patient will tell you I have a Fisherman's network rash. This is in case if he came in station 2, he will tell you I'm having a Fisherman's network rash. So what are the causes of livido-reticularis? It's a lividus EP. These are the causes of levodorsicleris. The causes are lymphoma, interferon beta, which is used in multiple sclerosis, or it may be idiopathic. So imagine a case with multiple sclerosis received interferon beta, and then they came with rash. Think about interferon beta as a side effect. Any vasculitis can cause levodorsicleris, especially arthritis nodosa and Churg-Strauss syndrome. Embolism, cholesterol embolism, and this is very common. You know, patients come to the cath lab to have coronary angiography, and after one day or by the end of the day, he starts to have this rash, and the peripheral pulsations is still to be weak. So this is a cholesterol embolism. Think about it. This is a scenario which is common. And D for Ehlers-Danlos syndrome, S for seropositive arthropathies. As we know, seropositive arthropathies are DARS, which is dermatomyositis, antiphospholipid syndrome, rheumatoid arthritis, Sjogren, systemic lupus, and systemic sclerosis. B, bromocriptine, dopamine agonist used in Parkinsonism. So a patient with Parkinsonism, he is on a medication, came with rash. Think about it may be bromocriptine induced, and finally pancreatitis. Sometimes you will not need to know all the algorithm. Sometimes you may capture the diagnosis from the first thing and you got the case from the start. So you should remember levodorsicleris, so the causes are levodos PP. If you are talking about erythema nodosum, so the causes are nodosum. Remember like this, inshallah it will be more easy. Okay, by the way, levodorsicleris improves with warming the area. Okay, doctor, what do you think about this rash?
This is necrobiosis.
Bioderma gangrenosa.
Yes, it's going more with bioderma gangrenosa. This is having, you know, necrobiosis, lipodycia. You know, lipodycia means lipids, and lipids equal fat, and the fat is yellow in color. So usually you will find yellow color here inside this ulcer. So this is, yes, a bioderma gangrenosum, and the concern from the patient, he may ask you, doctor, is it infective? So I can infect my son, I can infect my husband. No, it is not infective.
It is not infective.
It is not infective, okay, because it may be a concern. And the treatment, as we know, steroids, cyclosporin, and if failed, you can use topical tacrolimus, and sometimes it spontaneously remits. So what are the causes of bioderma gangrenosum? It's RIM, R-I-M. R for rheumatoid arthritis.
Rheumatoid arthritis. Inflammatory bowel disease.
I for
inflammatory bowel disease.
Yes, and M for malignancy.
Malignancies.
Yes, malignancy, especially blood malignancy. And in this case, don't forget to ask about extra intestinal manifestations in case of inflammatory bowel disease, which is a common mnemonic known as a PSAC. What's meant by a PSAC? Anyone knows that? What is this?
Uveitis.
Sorry?
Uveitis.
Yes, it's actually it is arthritis, bioderma gangrenosum, iritis, erythema nodosum, sclerosing cholangitis, I cannot remember the A for what, and C for clubbing. Anyone remember the second day? Because I cannot remember it well. Okay. So bioderma gangrenosum, it's a spot diagnosis. Levodorsicleris is a spot diagnosis. Erythema nodosum is a spot diagnosis with plus 2 words: non-itchy, painful. Okay. Next, what do you think about this rash, doctor?
Ichthyosis.
Yes, ichthyosis. Looks like a fish. So the patient will come to you, if he does not have the rash, he will tell you in the station 2, he will tell you, doctor, I'm having, my skin started to become like a fish scale. So think about ichthyosis. And this is very easy case, inshallah, and you will get it very rapidly, because the mnemonic for ichthyosis also from ichthyosis, but we will remove IC, and it will be thyosis only. So the causes of ichthyosis is thyosis, thyroid problems, hypothyroidism, HIV, and Hodgkin lymphoma. This is for the H, and H and Y together equals hydroxyurea, which is used in polythysemia. O for organ failure, renal failure, and liver cell failure. And S for sarcoidosis, I for inherited, and the last S for sarcoma. So there are some cases in dermatology, spot diagnosis, like psoriasis, like erythema nodosum, ichthyosis, livid reticularis. Lots of cases are going with directly with a spot diagnosis. So this is the case of Dr. Amr. Now, if you remember the first slide in which we talked about the approach to a rash, whether it is itchy or not, it was not itchy. So the second question is it taking a specific area or no? If it is not taking a specific area, so this is mostly a purpura. And we said purpura means blood oozing under the skin and mucous membrane. Why the blood will ooze under mucous membrane and the skin? It may be due to one of these 5 cases. Causes. Platelets V. So low platelets may be due to ITB, TTB, DIC, and this is part of Dr. Amr's case. The patient came to Dr. Amr having GERD symptoms plus purpura, and there is a strong association between H. pylori and the purpura, the ITB, because the antibody against the H. pylori cross-reacts with the antibody cross-reacts with the platelets and starts to destroy the platelets. So this was the case. Patient with purpura plus GERD, and this concern also should have been resolved, because Dr. Amr, if the patient is having H. pylori, he may be at risk of developing gastric lymphomas, and if you heal the H. pylori, 90% of the patient, you reduce the risk of developing lymphoma by 90%. So you should have been solve this concern and told the patient, I will do some tests for you, and I may refer you to the gut physician. He may need to do some extra tests for you. We'll start you in medication, because these medications will prevent further drawbacks of the organism that I am suspecting you may be having.
Yes.
Then after the P comes leukemia, aplastic anemia, trauma, enlarged spleen, liver disease, ethanol, toxin, systemic lupus, and lastly vitamin C. So these are the causes of purpura. Usually vitamin C deficiency does not lead to that this wide patches of purpura, but rather it leads to parafollicular hemorrhage. I mean hemorrhage under the hair follicle. You'll find very punctured hemorrhage under the hair follicles. So if you are studying, doctor, you can make scenarios for yourself or even with your study partner at these cases. For example, patient is having systemic lupus or patient on heparin, and this patient started to have purpura. So skin lesions. So think about purpura. Patient came with alcoholic patient. Okay. By the way, doctor, if you are having your exam in UK, don't use the term alcoholic. It's a very bad term. If you said alcoholic, it's a very bad term. It's better to use the normal term that, do you drink alcohol? Don't tell them, are you alcoholic? Because alcoholic means in our culture or even in their culture as if you are insulting him. Okay. Then talking about palpable purpura. Imagine, doctor, what can make the blood which comes under the skin, what can make it palpable? For sure, there is inflammation leading to raise of this area under the normal level of the skin. As we said, itis. So vasculitis leading to inflammation and finally leakage. So the causes are itis. I mean, most of the causes you will find, they will be inflammations. Most of them, the most important is vasculitis, and importantly, Wagner's and Henoch-Schlein purpura. So what's meant by Wagner, as we know, because it came before in a case in a history station. Wagner is a granuloma in the nose. It will lead to chronic sinusitis, plus or minus epistaxis. Granuloma in the lung, hemoptysis, shortness of breath, and in the kidney, and leading to glomerulonephritis and hematuria, and the patient will have this berberic rash. And the investigations, see ANCA, chest X-ray, you might find cavitations, and the treatment, steroid, cyclophosphamide, plasma exchange, and with a 10-year survival. Next, vasculitis, which is common to, any vasculitis can cause berbera. Wagner, Scherge-Strauss, polyarteritis nodosa, but these are the most important two, which are, the second is HSP, which is Henoch-Schönlein berbera, and this is a mnemonic for Henoch-Schönlein berbera. NABA for nephritis, hematuria, arthritis, berbera, and abdominal pain. So the patient will tell you, I have pain in my joints, I have pain in my tummy, my urine is red in color, plus rash. Next is polyarteritis nodosa, and again this is an itis, inflammation. In infective endocarditis as well, it's an itis. You will find here, sorry, by the way, in polyarteritis nodosa you can find hematuria, patient having chest pain, patient having testicular pain, and this is important, by the way, to ask him about testicular pain. And patients with polyarteritis nodosa, as we said in the previous slide, they will be having levodoreticularis. Doctors, I am sorry if I am talking rapidly. This lecture will be uploaded on YouTube, inshallah, so you can listen to it again if you want. So I'm sorry if I'm talking rapidly, just to save your time. Next is disseminated gonococcal infection. Oh, sorry. By the way, infective endocarditis, you should, if you're suspecting that this is infective endocarditis, ask about any recent procedure, any prosthetic heart valve, shortness of breath, chest pain, palpitation, new murmur as well, splinter hemorrhage in your examination rapidly. So in your case, the case may come to you completely different from this. Patient with prosthetic valve is having started to have rash. It can come as a history station. So think about it. It may be a berbera, and the patient is having inflammation leading to palpable berbera. And last one, Rocky Mountain spotted fever, and this is easy. Someone traveled to America and he had camps outside, and he may have tick bites. So from the common abbreviations, ITB, TTB, DIC, HUS, the only afebrile is the ITB, and the others are febrile. So it can help you also in knowing your diagnosis, enriching your diagnosis rapidly. Okay. So, doctor, we will say now, central to your ability to manage the dermatology case is to describe the rash. So, in your presentation, Dr. Amr, you should have described the rash well, because if you did not describe the rash for the examiner, he may give you mark. He may deduct from your marks. For example, this patient, so this patient is having bilateral small to medium-sized macular rash on both lower limbs. It's on both lower limbs bilaterally, no specific border and no secondary lesions. And we will know what's meant by secondary lesion. This is the way that you should present your the rash of the patient. For example, if you find we will say how to we'll discuss another case, inshallah. So inspection, this is important, doctor. You have to look at the table beside the patient, because you may find an emollient beside him, and the patient, for example, is having psoriasis or this ichthyosis, and he is having emollient, using emollients for this. So inspect. It will not take from you anything to have a look beside him. Okay. And in the rash, you should comment on this 6S. So 6S in the rash: size, small to medium sized, site, these are in the both lower limbs, and the side, the margin, sorry, the margin, and the shape, the shape means the type, macular rash, papular rash, or ulcer, or whatever. And the secondary lesion, like scales, for example, if they present, or it may be covered with crust. So what is the difference between a scale and the crust? Crust is a dried sebum. Crust is a dried sebum, but the scale, this is the most exterior surface of the skin, the most exterior layer of the skin. So it's easy to know whether it is covered with scale or crust. Okay, if you the morphology may be diagnostic, as we said, like in vitiligo, in psoriasis, in erythema nodosum, leafy glands, and you don't need to dig deep and deep from the beginning. But if you remember at least the mnemonic for this, you will inshallah get the case. Because you know the issue is not only to get the case, is not only to get the diagnosis, but to know the diagnosis and to manage the diagnosis, to manage the etiology, and to manage the complications. So if you got a case, if you got your diagnosis at any time, you should do two things. Number one, go one step backwards and one step forwards. One step backwards to know the etiology and to treat the etiology if it is present. Like in this case, okay, you are having ITB. This ITB, it's a complication of an H. pylori. So I have to treat also H. pylori, because now you are treating only the symptom, or sorry, the complication. So if you treated the complication and left the main problem, the complication will come again. So if you get any diagnosis at any station, station 2, station 1, 2, 3, 4, 5, any station, you have to ask about complications and ask about etiology if you have time. Or at least you have to tell the examiner, okay, sir, I need to search for the etiology and search for the complication. Don't say, for example, if you forget the etiology of a disease or a complication, at least tell the, oh, sorry, Dr. Imran, your webcam is open. Can you please close it? Okay, thank you. So if you get a diagnosis, at least if you forget what are the causes or the etiology, at least tell the examiner, say, I'd like to do investigations for etiology and complications. If you forgot, and it will give you more time to think what may be the etiology and what may be the complication. You will give yourself extra 5 seconds to think at least. Okay, so you have to comment on the lesion. This is very important. Don't miss it. It will not take 10 seconds from you. And this is the main thing they are the main skill they are testing your ability in this station is how to describe the rash, because you know most of us is away from dermatology and we don't know how to describe the rash well. So I suggest doctors to open the internet and look for any rash and describe the rash. Try to describe the rash, any rash on the internet, even if you know the rash. For example, pyoderma gangrenosum, you have to describe the rash as a size. For example, it's about 5 centimeters, and the left lower limb, the margin is well demarcated, and the shape, it's rounded on one side only, and for example, it's covered with crust. Now you describe the rash very well, and he will give you the full mark for describing the rash. So again, as we said, the morphology may be diagnostic from the first look, and if it is not diagnostic, like for example perbra, you should comment on differential diagnosis, as in this case, if you don't have, because you know how many of us know that there is a relation between H. pylori and this ITB. Before, I don't know that there is a connection between both of them. So if you get the case and you don't know, at least comment on the differential diagnosis. So sir, I am thinking this patient is having palpable perbra, and she's having another symptom. She's having GERD. I'm not sure if this GERD is related to the perbra or no. So I have to ask my seniors about if there is any relation between both of them or no. However, I have a list of differential diagnosis for this perbra, which are platelets V. And then if he deducted anything, he will deduct a small mark from you. These are important hints in this station. Don't forget to ask about how and where did it start, past history of atopy, hay fever, bronchial asthma, eczema in the patients and the first degree relatives. Review other systems, and it's important to ask if there is a recent infection. I guess maybe the patient came with fever and rash. What is the most common cause? Till proven otherwise. Hello, doctors, do you hear me?
Meningitis.
Fever and rash. What? Yes, meningitis. Meningitis. This is the most. Yeah, if patient came with fever and rash, think about yes, meningitis still proved otherwise. This is because this is the most dangerous. Okay. Travel history is important. If this patient's having swimmer's itch, if you travel to Brazil, and Dr. Amr did well and asked about this. Drug history is very important. Very important. Doctor, put it as a rule in your paces. Drug history is very important. You should ask about drug history at the third question. Please don't put the drug history as we put in the history station. And because in the history station we ask about complaint, then review of other systems, then past history, and then past history we ask about chronic diseases, blah blah blah, and finally we ask about drugs. No, please here. Can you show me this rash, please, sir? Is it painful? Is it itchy? Are you using any medication, sir? He will tell you yes or no. So, or we will set another example. This patient came with rash on the flexor surface of his hand. You asked him, show me, please, sir, and you found lichen planus. Sir, are you using any medications? He will say to you, yes, I'm using thiazide. Now you got the diagnosis because thiazide can cause lichen planus. See how it is easy? Please don't put the drug history, don't delay the drug history. Put it the second or the third question after immediately describing the things. One point I want to comment on this, Dr. Amri, when you took this case, especially in station 5, please give the patient time to express things. I will tell you what do I mean. In this station, the patient came with rash and you started to analyze the rash. And then you started to analyze other systems. Doctor, you don't have time in station 5 to do all things. So after asking about symptoms, the main complaint the patient came with directly, sir, do you have any other problem? Because if you remember, I told you myself that I'm having some water brush. I told you myself. You didn't ask me. You know, sometimes the surrogates are helpful and sometimes they are not helpful. It depends upon the examiner and the preparation of the station. So after asking about symptom, do you have any other symptom, any other new symptom? You should ask him this question. Give him time because he may give you the clue. If you didn't ask him, if you left these things and started to analyze the systems, he will not tell you, stop, doctor, I'm having another problem. He will not tell you like this. So please, after analyzing the main complaint, well, then ask and the related, the related symptoms, like the patient is having rash and or patient, for example, having a tummy pain, you have to ask him, do you have any nausea, vomiting, hematemesis, melena? I mean, not in medical jargon. Hematemesis, melena, tummy pain, like this, diarrhea, constipation. Finished, okay? Do you have any other symptom, any other problem, any other complaint? At this time, he will tell you, doctor, yes, I'm having another complaint, and it will be the clue for your exam, for your case. So again back, we said we should ask about how and where did it start. Why? Because you know, bullous pemphigoid started as bully and rupture. Pityriasis rosea starts as Herald patch, then small rash. I'm not sure, usually they don't bring this case, Pityriasis rosea, because you know, it's a self-limited, maybe within 1 or 2 months. So usually they don't bring cases like this. But at least if he asked you what other rashes, why did you ask him, how did it start? You will tell him, sir, because some rash starts in a specific type and then it changed to another type. For example, patients with this biodermagangiosum stretches as red area, then become ulcerated like this. If you find depigmented lesion, I mean white lesion, it may be vitiligo or ash leaf spot. Please, doctor, if you had a look at ash leaf spot on the internet, yes, it may you may find it on the back. It's hypopigmented. So don't think that this is only a vitiligo. It may be an ash leaf spot. And if your case of vitiligo, for example, if you asked a child with a 6-year-old about vitiligo, he will, if he saw it, he will tell you that this is a vitiligo. He will not bring a case of vitiligo in the exam just to tell him that this is a vitiligo and I would like to refer him to give him camouflage cream or some protecting creams and refer him to dermatologist. No, he will give you a case of vitiligo because he wants you, because vitiligo is an autoimmune disease. So you should search for other autoimmune diseases in this case. So don't think that this is your case. Another thing may be hidden inside this case. And if you find any autoimmune disease, please, doctor, ask about other autoimmune diseases. Last thing is telangiectasia. What's meant by telangiectasia? It's a visible dilatation in the skin blood vessels. Photosensitive rash, porphyria cutanea tarda, dermatomyositis, drug-induced systemic lupus. Drug-induced, what are the drugs that may cause photosensitive rash? Any drugs containing sulfa. What are the medications that are containing sulfa? ACE inhibitors, diuretics, sulfasalazine medications, penicillin, but penicillin, I don't know if it is containing sulfa group in its chemical component or no. But it can cause photosensitive rash, by the way, I didn't write it, sorry. Tetracyclines and non-steroidal. We finished the algorithm for rash. I hope that it will be beneficial to my colleagues. Do you have any question till this point, doctors? Any doctor having question in this point? And unmute. I unmuted all physicians.
Thank you, Dr. Khalid.
Okay. So we will take another case. We will take another case. I will mute all you physicians. We will take another case. It will be also dermatology case. So any physician wants to take the case, he can send it to me. He can send private messages to me.
Thank you, Dr. Khalid. Very much informative.
Thank you. I'm just trying to get the main screen because this is the first time for me to use Zoom from the computer. Usually I use it from my mobile. Okay, I got it. Okay, thank you, Dr. Okay, anyone wants to take the case? We will have another case, doctors.
Okay, Dr. Khalid, I can take the case if you need it.
Okay, who wants to take the case? Dr. Home, because Dr. Home?
Walid, Dr. Khalid.
Okay,
yeah.
Dr. Walid. Dr. Walid, can you talk, please? Because I'm not sure if I muted you or no. I will unmute you, sorry. Dr. Walid, you are unmuted now. Okay?
Yes, yeah.
Okay. I will tell you the case by because I didn't prepare it like this case. I mean, I didn't write it at the previous case, but I will tell you now. This is a history station, Dr. Walid.
Yeah.
1 second, please. I'm just will give you 5 minutes to think about it.
Just make I get a piece of paper and pen, Dr. Khalid.
Sorry?
I'll just get a piece of paper and pen to write after you.
Okay, go and fetch your paper and I'm waiting you. It's okay. At least we have to take a little bit rest. Okay. Sorry, I forgot to talk a little bit about the previous case, the case of Dr. Amr. So the case was ITB, idiopathic thrombocytopenic purpura, and we said that there is association between H. pylori and the ITB. So what's meant by ITB? We said it's called idiopathic or immune thrombocytopenic purpura. What happens here? Just I will write on the screen. Bismillah.
I'm ready, Dr. Khalid.
Just Dr. Walid, wait please a minute, because I forget to tell something about this purpura. So doctors, can you please, doctors, look at the dashboard? So in the final common pathway, of coagulation, we have a receptor called glycoprotein. Sorry for my writing. Glycoprotein 2B3A. So this receptor, this is the final common pathway in patients with, in the coagulation cascade. This is the last thing. If you inhibited this receptor, the patient will bleed. Doctors who are working in ICU or CCU or cardiology or any physician, if you know a medication called agarastat, you know, it's a common medication, agarastat. It's used agarastat, okay, for aggregation stat, you mean stopping of aggregation. So agarastat does exactly what ITB does. So ITB, there is an antibody will attack this receptor, and the agarastat as well will inhibit this receptor because it's called glycoprotein 2B3A inhibitor. So ITB attacks this receptor. So in the explanation, Dr. Amri should have a paper and tell the patient what we are saying now. So sir, or Miss, I cannot remember the name, Miss Healthy, you know, if we are injured at any area of our body, if this is the bloody channel, okay, then don't say conduit. If you are examining in UK, please don't say blood conduit. It's called bloody channel. If this is a bloody channel, and if we injured here, for example, and the bloody channel open, we have small things in our blood called platelets. This platelets blocks this injured site. What happened in your case? What happened in your case in this? There is something we call receptor on this platelets being attacked by your defensive system for a cause we don't know. We don't know why. What makes it? The defensive system attacks your platelets, and then the blood starts to come out from here to be settled under your skin. I'm so sorry to tell you this, but you know, we have to do some tests for you, and then talk to the examiner. When the examiner asks you, because he will ask you what are the investigations, so we'll tell him antibodies against platelets, bone marrow aspiration, and we will find megakaryocytes, and this is important to do bone marrow aspiration in this case before starting steroids, because it may be a blood malignancy, leukemia, okay? He will ask you, what are the medications you know for this case? So you tell him steroids, dramatic response, about 80% of the cases, cyclophosphamide, Splenectomy may be needed after 3 months if platelets is still less than 30. So sorry, I will write them. These are the treatment. I will write them. I'm so sorry. All problems. So so this is a treatment of ITB, doctors. Steroids. Okay, plus or minus cyclophosphamide, intravenous immunoglobulins, sorry, splenectomy after 3 months if platelets still less than 30. So this is the treatment. ITB can cause death. Yes, it can cause death. So you have to give idea for this patient about whether she should be admitted or no, and she should be very cautious. She should be very cautious because you know if she had any hit at her skull, she may die from intracranial hemorrhage, and this is the most common cause of death in patients with ITB, which is intracranial bleeding. Okay, so this is the case that we just finished. Bismillah. I will remove this one. I will prepare the case for you, Dr. Walid. 1 second, please. Dr. Walid, you can hear me? Hello? Doctors, do you hear me, doctors?
Yes, I hear now.
Okay,
Yes.
Dr. Walid,
Yeah,
I think he left. I think he left.
No. I am already here.
Oh,
I
you're
am
here.
already
Oh, sorry. I will unmute you, Dr. Walid. 1 second, please. Okay, Dr. Walid.
Okay, doctor.
So this patient, she's a 40-year-old lady. I will write to you on the board. Bismillah. So this. So يا أخي تعال So Mrs. Rose, she's 39-year-old lady, came with skin rash. Please see and examine. Answer any concerns. I'll give you 5 minutes, Dr. Walid, to take your time preparing your case. And other doctors, you can also plan in your mind.
Okay, Dr. I'm ready now.
Okay, doctor. 1 second, please. I'll make a timer for you. It's a history station, by the way, okay?
Okay.
Okay, Dr. Walid, you can go on.
Okay. Hello, this is Mrs. Rose, 39-year-old.
Yes, doctor, I am here.
Yeah. Hello, Mrs. Rose. I'm Dr. Ali, one of the medical doctor here today. Can I have to discuss with you the reference letter that from your GP about your skin rash?
Yes, doctor, for sure.
Yeah. Do you mind that I'm writing some notes while we are talking, and just to be sure this is most confidential, and this one will be just for the sake of reaching your diagnosis, and all my attention will be during that with you. Sure, it's okay with you?
It's okay, doctor, yes.
So I receive a reference letter from your GP stated that you have a rash in your skin. Can you tell me more about that, please?
Yes, doctor, you know, for the last 3 months, I started to have rash in in both my lower limbs. You know, it's worrying me because, you know, I'm 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 jogging every day. You know, I'm like I wearing my shorts and I run in the track every day. But you know, for the last 3 months, I cannot do this because this rash is worrying me and it's disfiguring my lower limbs. I don't know what this.
Yeah, sorry to hear about that, Mrs. Rose. So for
Thank
this rash, it is just first time to appear?
Yes, doctor, this is the first time.
So you don't have ever experienced any rash before? Like
No,
this one, I mean?
no, never, I don't.
It's only 3 months, I'm right?
Yes, 3 months.
Yeah, on both legs at the same times, or on start in one leg, they move to the other one?
I cannot remember, doctor.
Yeah, okay. So this rash is increasing by time?
Yes, increasing by time. Yes.
Yeah, and this rash is itchy or not itchy?
Sorry, doctor.
Is it itchy?
No, not itchy, doctor.
Not itchy. Is it oozing?
No,
Yeah. Is it raised? You find it raised from your skin?
raised from my skin?
Yeah.
No, it's not raised.
Yeah. Yeah. How did it start, this rash? It start from the start as it is now, or it just started and increased, or have any changes in its size and size?
Have a change in what?
In the size or in the shape all over the course, or it is the same
No,
like
the
it started?
shape is the same shape, but the amount, you know, doctor, is increasing. It's increasing more and more.
You mean increasing in the size?
Yes, yeah, it's increasing. It's involving my. It starts in my the extremes of my foot, then started to go up. I don't know what is this.
Yeah, it's also involve your back or your belly, or it stopped at the level of the lower limb of
No,
the leg.
no, it's extending even to above my knees as well.
Yeah. Sorry to hear about that. Can you show me this rash, if you please?
No, this is a history station, doctor.
Sorry, I'm so sorry, doctor.
It's okay.
So for this rash, is it any vesicle formation or any fill with fluid or something like that, or no?
No, doctor, no fluid, nothing like this.
Nothing at all. What's the color of this rash?
It's brownish, like sometimes it's brownish in color. Yes, like this.
Mhm. Does it have something that increase the rash or decrease the rash?
Sometimes it improves with warming. Yes, decreases a little bit with warming.
Decrease with warm?
Yes.
So is it have any relation with sun exposure?
No,
Have any relation to the cold?
no,
So you say it's decreased by warm, I'm right?
yes.
Yeah. So what else other than this rash you have?
What else? Like what, doctor?
Do you have any other complaint other than your rash?
Yes, doctor. You know, for the last 6 months, nearly, I was following with my GB for routine checkup. He told me that my blood pressure is a little bit elevated, but I didn't pay attention for this because, you know, I don't like to take medications. But as far as I remember, it was 150 over 94, like this. Yes, it was elevated to this extent. Otherwise, other than from this rash, sometimes I have, what else? Sometimes I have some tummy pain. That what can I remember?
Yeah. So for this high blood pressure, did you started on any medication?
No, doctor, I don't like to take medication usually. He told me that we may try some lifestyle modifications, and he asked for some labs. But actually, yes, he took blood tests for me, but I didn't follow up again with him. I don't know even what are the results of this blood tests.
Yeah. So I advise you to follow up with your GP about the blood pressure, so it don't reach a critical level that you need to follow up later.
I will think about it.
Okay. What about the abdominal pain? You say you have some tummy pain. Where is it located?
Sometimes it's all over my tummy. Sometimes.
Yeah. So when was it started?
When?
When was that pain started?
Maybe for the last 6 months as well, with my high blood pressure.
Yeah. So for this pain, does it travel anywhere or only in your tummy?
The pain what? Travel? No, doctor. I cannot feel pain in other place. It comes here in my tummy.
So where exactly in your tummy? On the sides or in the center of your tummy?
All over my tummy, doctor.
All over. Does it have any, does this pain has any burning sensation in your abdomen or no?
Burning sensation? No.
Yeah. So what look like this pain? Is it dull aching pain or stabbing or burning or what kind of pain this one?
I cannot remind, doctor, because it is not on daily basis with me, you know.
Yeah. So what about your appetite? Is it good?
My appetite is not that good, you know, and even sorry, my appetite is good, and despite this, I found myself losing weight. I don't know why. I'm losing some weight, despite my appetite is okay, and the the and you know, I stopped jogging because of this rash. I stopped jogging. I don't like people to look at my legs with this rash. I stopped jogging, and if I stop jogging, my weight should increase. Now I find my weight decreasing. Very strange for me.
Yeah, yeah. Sorry to hear about that. So for that weight loss, you have any fever?
Fever?
Yeah.
No, doctor. I cannot remember like this.
You have any sweating?
Sweating? No.
No. No night sweating or excessive sweating?
No, no, no.
Nothing like that. So you have any joint pain?
Joints pain? Sometimes I have joints pain, but it's not that severe. It's not annoying me, but sometimes I feel it.
Yeah, this joint pain is related to your hands or your legs or your feet?
Sometimes in my hands, sometimes in my foot, but I thought that it may be due to, you know, because the year and year I do exercises, sometimes heavy exercises, so I think it may be due to it.
Yeah, any stiffness in your joints also? No.
Stiffness? No, doctor, I don't feel stiffness.
No stiffness like that.
No.
What about any lumps and bumps on your body or no?
Lumps and bumps? No, I did not feel any lumps and bumps.
Nothing like that. Any headache?
No, doctor.
Any problem with your bowels, like you have any diarrhea or constipation?
Diarrhea? What's diarrhea, doctor?
You have, sorry, any loose motion?
No,
or
no,
any
I don't.
constipation?
I don't have.
No loose motion, no constipation, right?
No.
Yeah. What about your water work? You have any problem with your water work?
No, doctor.
Any change in color of urine?
No.
Any increase or decrease in the volume of your urine?
No.
Any back pain?
Back pain? No, doctor. I did not feel like this before.
No back pain at all. So what up? You have any shortness of breath?
No.
Yeah. Any cough?
Cough? No, I'm okay as regard this point.
at all? You have any sore throat or any
Sore throat? No,
running
doc.
nose?
No, 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 no.
Nothing. Nothing.
No.
You have any awareness of your heartbeats?
Awareness of my heartbeats? Never, doctor. But you know, my heart. I know that because I'm using my smartwatch, my heart rate is usually 50s to 60s.
Yeah, yeah, it's good for you. So, any throwing of food or throwing up of, of your abdomen or any abdomen pain, other
No,
than
doc.
the kind of pain you have
No, no, no,
at all.
no.
So, for the meantime, you have any chronic illnesses should I be aware of?
Chronic illness?
Yes.
No, doctor. Apart from this high blood pressure, before that I didn't follow up with it. I don't have anything.
Any problem with your sugar?
Sugar? No, my blood sugar is okay.
You are not on any kind of medication, even of over-counter medication?
Over the counter medications? No, I don't use them.
You don't use them also.
No.
So you have any recent admission to the hospital for any medical issue or any surgery or something like that?
No, doctor. No.
You have any history of blood transfusion?
No.
Nothing like that.
Yes.
So you check whether you are pregnant or no.
No, doctor. I'm not sexually active.
You are sexually active.
I am not. I am not sexually active.
You are not sexually active. So it's a private question. Can I ask about your periods?
Period. Yes, you can ask. Go on.
Yeah. What about your period? Is it regular or irregular?
Regular.
Regular. So it is the same amount of blood is
2
coming.
minutes
Or
remaining. 2 minutes remaining. Okay.
you have any recent travel?
Travel? No, doctor. I don't.
You don't have any. You are a smoker.
Yes, I'm a smoker. Yes.
What about your smoking?
What about my smoking? What do you mean by the question?
How much you smoke?
Maybe 1 packet per day.
And alcohol?
Alcohol, occasionally.
Okay. So for the meantime, can I know what's your concern?
I'm concerned about this rash, doctor. You know, I'm afraid it's disfiguring me so much. I don't know what's going wrong with me. Maybe I'm not sure. It maybe I may have a skin condition. I don't know what's going on.
Actually, I appreciate your concern. For what I informed about your history and such conversation, give a list of possibilities for your rash. Some of these possibility may we consider it like you have a problem with your what's called your platelets. It's a cause. This is a element of your blood cells that cause blood vessels or blood channels not to bleed. But according to what you just mentioned, in the presence of your weight loss and the abdominal pain, it comes to our mind that you may have an issue with your platelet count, so that we need to run series of investigations and to refer to a multidisciplinary team for the routine blood tests and ultrasound. It's an image for the abdomen to check whether you have any problem with your internal organ of the abdomen. And we'll take it after that. We have another meeting after the completion or after release of the results of your blood test and the abdominal images. So you have any other concern, Mrs. Rose?
Yes, doctor. You know, for this weight loss, I'm afraid I may have a cancer. You know, one of my friends, she had weight loss before she discovered that she was having a cancer, and she died within 6 months.
Actually, cancer is on the bottom of my possibilities for your case. That's why we need to run this kind of blood tests and the images for your abdomen. And after that, we have another meeting to discuss the possibilities that we have. For the meantime, I shall admit you, I shall run this test on outpatient basis, and according to the result we will have, we will see whether we will admit you on view of this lab or no. So you have any other concern?
So you will admit me, doctor?
No, we run these tests first, then after that we will see.
Time. Okay. 2 minutes for discussion. What's your diagnosis, doctor?
Actually, for my differential diagnosis for this patient, maybe she has issue of idiopathic thrombocytopenic purpura also. This is one possibility. And the other possibility may be noxion line purpura in view of her abdominal pain and recurrent joint pain, but it lacks the presence of the fever or urinary complication.
Okay. So why do you think that she is having idiopathic thrombocytopenic purpura?
Actually, it's the diagnosis of exclusion. On view of her history, I don't find any other possible cause that supports other diagnoses. For example, she don't have any features of infections that run or are complicated with this purpura, and also she is, according to her age and her complaint, she's a little bit away from the issue of malignancies. So by exclusion, it can come like ITP.
Okay, so doctor, do you think that asking here about the shape of the rash may solve the case for you? For example, if you ask it here, what does this rash looks like? You think that it may solve the case for you?
Yeah, I forget to ask about it, sorry.
Okay, doctor. So this patient had some weight loss. How many kilograms she lost?
No, I don't investigate the weight loss properly. Yeah.
Okay. So also she had some hypertension, as she said. Did you offer to measure her blood pressure in the clinic, or to?
Yeah, she has hypertension. If I'm not wrong, she is complaining of hypertension. I'm right?
Yes.
Yeah. I don't order. Yeah. No, I didn't order.
Okay. So this patient, doctor, had some some psychological affection due to her lower limbs. What about her mood now? Do you think that she is stable? I mean, she is in severe depression, or just seems to you mild depression, or what?
Actually, she's concerned about the issue of this rash for her jogging daily basis jogging. So sure, it affects her mood. But I didn't ask about the other mood warning signs or depression signs.
Okay. So what's your management plan?
For this patient, first, I will take a routine lab, including her CBC, coagulation profile, platelet function test. And we will send also for her blood film for evidence of any abnormal platelet clumps. Also, we will do for her autoimmune profile to find any autoimmune elements for possible thrombocytopenia. Also, we will refer the patient to multidisciplinary meeting, including the dermatology doctor, the medicine doctor, and we have another meeting for the patient after the result of this lab and meeting. Also, we will have some images for the patient in form of abdominal ultrasound to rule out any splenomegaly that may be a cause of possible thrombocytopenia or any lymphoproliferative or disorder. That's for as a beginning.
Okay, thank you, Dr. Reed.
Thank you.
Okay, Dr. Reed, mashallah, you did good in analyzing the history of the patient. But to complete the picture, we have to, I'm so sorry for my attitude, but as I told you, I'm trying to be as silly as them as possible.
We wish to be more, Dr. Khalid.
Yes, because they are more silly actually in the exam.
I know, yeah.
Okay,
yeah.
So so taking the point from the start, as we said before, in station 2 or in a station, the stations in where there are some talking, you will find the paper outside. So when you find the paper outside, doctor, please divide this paper in this way. Please look at the board. Divide the paper in this way. Here, you will write your differential diagnosis. And the differential diagnosis here is the mind map, if it is present, mind map. This patient came with rash. So how did it start? And then biopsy, and then is it itchy? Oh, sorry, itchy or no? So if it is not itchy, is it so if it is not itchy, is it taking? Is it in a specific? Sorry, doctors, for my handwriting, it's not good. Specific, is it taking specific area or taking, or taking special shape? If you ask this patient about, does it have a special shape? He will tell you, this rash looks like a fisherman's network rash. So now you know, where are you going? You are going to talk about livido reticularis. Put it in your mind and continue your case. Don't ask it, because you know, and you are not saying in the rash, so you have to ask him. He is the one that he is having the rash, so ask him to examine himself instead of you. So ask him, where this rash, site, size, shape. Don't forget shape. So in this station, you will ask him to examine himself instead of you, on behalf of you. So the success, site, size, shape, secondary lesions, and symmetry. If you told him, what was the shape of this rash? What does it look like? Is it taking a specific shape? He will tell you, yes, doctor, it looks like this fisherman's network rash. So at this point, you can stop for, tell him, okay, just give me 10 seconds. I will just write these things down. And then inside the station, you can write the differential diagnosis of livido reticularis and then ask about them. And we said, in the slide that livido reticularis having a differential diagnosis. So if you mention them, if you reminded them, you will get the diagnosis rapidly, inshallah. So in your differential diagnosis, put it outside. Here, the management plan, IS, which are idea, concern, and expectations. Ideas, talking about what's the difference between all of them? Idea is a past event. Idea, I came to the hospital with an idea that I may have a concern, which is a cancer. What the expectation? I'm expecting you to admit me. For example, what's your ideas? What are your concerns? And what are your expectations? Here, doctor, please, this is the most important thing. This is the most important quarter in station 2. The positive data. Please, doctor, anything abnormal you should write here, because you will have mental block inside the station. So the positive data here are rash. The positive data are weight loss. The positive data are hypertension, some joints pain. She thinks that her joints pain due to her jogging, but she is jogging. Why she will have joints pain in her hands? Okay, so these are the positive data, and you should analyze very well. Don't miss anything. So please don't forget this part. This is the most important quarter in your station. Come here, and this is the place that you will play in. Here, the CRB first. 1, 2, 3, 4. CRB first and WT. So C for the complaint, analysis of the complaint, as we know, onset, course, duration, blah, blah, blah. are a review of other system. And here comes the past history of diseases, medications, blood transfusion, hospital admission, family history, and drugs, family history of similar conditions, family history of consanguinity if it is related, and family history of chronic diseases. And here comes allergy to food and medications. And then S comes for the sexual history. Please, doctor, don't ask the patient. See, don't ask the patient, are you sexually active or not? Just ask her, are you married? No. If she is not married, okay, then you can ask her sexually active. Because if you ask her, are you sexually active, or you are having multiple relations and she is married, you know, it's not good. So the sexual history, in the sexual history, if it is related to your condition, for example, patient came with ulcers, and you are thinking that this ulcer may be related to HIV, or so you have to ask specific questions in the sexual history. So ask about, are you married? Yes. Do you have any extra? I'm so sorry to asking you this questions. It's not for you specifically, but usually we need this question just to know. We ask it to all patients to know how is the situation. He will tell you, that's okay, doctor. Okay. So tell him, are you married, or are you married? Are you sick? Okay. Do you have any extramarital relationships? Yes, doctor, I have. Sorry, I'm so sorry. Sorry, don't say so sorry for this. Is it homosexual or heterosexual? What is the preferred route? Oral, vaginal, or anal? Okay. Then S for social history. Social history is smoking, alcohol, bets, if he is having a bets at home, especially in cases of shortness of breath. And this may be the clue. Patient with parrot in his home, or a dog, or a cat, and he is having extrinsic allergic alveolitis, came to you with shortness of breath. So this may be the clue, the bet. And the habits. Habits are important. And the S here for psychological history. You know, this patient is having some depression, doctor. How to ask about depression? Ask about depression this way. How about your mood? She will tell you, I'm good. Okay, here it's okay. Don't ask other questions. My mood is good. But if she told you that her mood is not good, so you have to dig more and more. So if she told you my mood is not good, I'm so sorry for this. Do you have any bad ideas about life and death? Did you try to harm yourself before? She will tell you, no, that's okay. So this is a mild depression just due to her issue. Okay. Then comes to the T, which is the travel history, and very important, travel history. Here, weight and temperature, very important. And if we talked about weight, you should analyze the weight. This patient, Dr. Walid, told you that she lost her weight, and you bypass this issue rapidly. You should ask, if she told you, I lost my weight, she told her, is it intentional or no? Is it intentional or no? If it is not intentional, how many kilograms did you lose? She will tell you, I lost 2 kilograms. For how long? For the last 3 months. It is not that, you know, because, you know, weight loss to be significant, it should be 10% of the total body weight within the last 6 months to think about malignancy. Okay, so this is how to deal with the case of history. Please don't forget to put a mind map to yourself before entering the station, because you may lose things inside. So we will go back to our case. What happened in this case? I will clear these things, okay, and then I will share the. I will share the slide again with you. You share. We will go up here. This was our approach. Oh, sorry, I will share it. Can you see it, doctors, now? Doctor, can you see it?
Yes.
All doctors are unmuted. Okay, you can see the slide now, doctors.
Yes, doctor.
Okay.
Yes, sir. Yes.
So in the beginning, ask the patient, do you have any rash? She will tell you yes. Is it itchy? No. She told you it is not itchy. So the second question, then ask about it is not taking a specific area. It's not taking a specific area. Does it have a specific shape? No specific area. No specific area or specific shape. I should have wrote it here, but I will upload it, inshallah, don't worry. Then if you ask it here about the shape, she will tell you that I'm having fisherman's network rash. Then this is your differential diagnosis. Ask here that I will write something, and okay, take your time, write in 20 seconds, in 1 minute, no problem, but at least you have to write these things down. And then ask here about packages here. For lymphoma, this is a malignancy, so you should ask here about night fever, night sweating, loss of weight, loss of appetite, any lumps or bumps in her body, especially in her neck and armpit. Interferon, ask here, do you have did you have any problem with your are you using any medications? No, so it's not interferon and beta, and it is not bromocriptine. Then ask here about vasculitis. This patient, Dr. okay, we will let it to put it to the beginning. Embolism, cholesterol embolism. Do you have any recent procedure? She will tell you no. Do you have any elasticity in your joints or joint dislocation before, or shortness of breath, or racing of heartbeats? These are the manifestations of Ehlers-Danlos syndrome. Then finally, you will be in one of these two diagnoses, either seropositive arthropathy or vasculitis. This patient had weight loss. This patient had hypertension. This patient had rash in her body, and she is occasionally having some tummy pain. What is the condition that brings this? Churg-Strauss vasculitis? No. Dermatomyositis? No. Rheumatoid arthritis? No. So the diagnosis is polyarthritis nodosa.
Yes.
Okay. So if you didn't follow a specific mind map or a specific algorithm, you may be lost inside the station. So make a mind map for yourself from the beginning, that make your differential diagnosis, and then you will get the full mark, inshallah, very rapidly, and the examiner will be impressed from your attitude. Okay, so talking about polyarthritis nodosa, doctors, I have to mention three things. And when I mention these three things, please open your eyes completely. Stare, please, stare. You know why? Polyarthritis nodosa can cause fever. Polyarthritis nodosa can cause anorexia. Polyarthritis nodosa can cause weight loss. Polyarthritis nodosa can cause high ESR. These are the manifestations of cancer as well, So don't rush directly to cancer. Yes, she may have some fever, weight loss, and anorexia, and high ESR, and he may distract you with putting ESR in the beginning of the exam station. So don't worry, go very simply with the algorithm or the mind map, and you will get it very rapidly, inshallah. If this was a male patient, so you have to ask about what?
Testicular pain.
Yes, testicular pain. Testicular pain, and you may get the case from testicular pain, by the way. So that here, I brought the case to you as a female, because if you asked me, do you have any pain? And I'm a male, I would have told you I'm having testicular pain, but I didn't know to do like this. And then hypertension, please, doctor, if you wrote the things in your positive data, inshallah, you will not miss anything. Because can you please tell me, how will you attribute things to each other in a place where you are traveling from far away and staying in a hotel for 1 or 2 days and being stressed in the day and the day of the exam, and you didn't sleep, and you entered the first time you meet such types of patients in another country, you think that you will attribute things in your mind together? No, doctor, it will not happen. And if it happened, so you, I will envy you for your for being called like this. So you have to write everything. This patient's having weight loss, hypertension, some chest pain, some and rash. What the thing? Okay, I will go with the mind map and I will get the case. So finally, what are the investigations that we should do in cases of polyarteritis nodosa? Any doctors know?
CBC, ESR, or arteriography, ECG.
What else? Any doctor can say, it's okay. ECG,
Biopsy from the lesion.
ECG, doctor, why you don't?
Sorry?
Why you don't? You want to do ECG?
Because these patients can develop the hypertension to see the changes of
Very
left
good.
ventricular hypertrophy.
Very good. Very good.
Arteriography, angiography, and biopsy of the lesion and CN profile.
Okay. but why you missed the basic investigations like CRB, ASR, Bianca? Despite being negative sometimes, Bianca, but you have to mention it. And there is something which is having a strong association with polyarteritis nodosa. Yes, polyarteritis nodosa, hepatitis B.
Yes.
Because the treatment depends only on the type, on the cause of this polyarteritis nodosa. If it is secondary to hepatitis B, so you lose steroids and hepatitis B antivirals. If it is not, you will use steroids and you will use cyclophosphamide with it. Okay. So we are now at the end of our meeting. I hope that you get benefit. Inshallah, we may meet tomorrow or after tomorrow if I have time. Inshallah, I will upload this lecture on on YouTube, and we have a group. Inshallah, I will send you on the net. Inshallah, I hope that you will get benefit from it. Any question, doctor?
Thank you.
Thank you, doctors. Thank you. Assalamu alaikum.
Thank you, Dr. Khalid.
Welcome, Dr. Thank you.
Thank you so much.